Good afternoon, everyone. My name is Zara Premji, and it's an absolute pleasure to be here with you today. I'm a host and reporter at CBC News in Vancouver. Very excited to not have to be in a newsroom today and just get to come to you virtually from my couch. I'm delighted to be your moderator for this webinar entitled The 21st Century House Call: Is Virtual Health Here to Stay? A big question many of us have had over the last few months. This is the second webinar in the Transforming Health for Everyone webinar series, brought to you by UBC Faculty of Medicine Development and Alumni Engagement, rather. So I'd really like to thank you by beginning and acknowledging that UBC's Vancouver Point Grey campus is situated on the traditional ancestral unceded territory of the Musqueam people, and UBC Okanagan is situated in the territory of the Salix Okanagan Nation and their peoples. I would also like to recognize that you are joining us today from many different places, near and far, and acknowledge the traditional owners and caretakers of those lands. Now, if you don't know whose land you actually sit on and would like to find out, I would recommend that you head over to www.native-land.ca to find out. I know I've moved around many different places in Canada, and I often look that up. I think it's really important to know where exactly we are. It's a really great resource. You know, we have seen a rise in racism towards Indigenous, Black, Asian, and people of color in communities around the world, and it's important to acknowledge the systemic barriers marginalized groups continue to experience. Now, I encourage everyone participating today to join the UBC community in reflecting on what actions we can take individually and together to promote diversity, equity, and inclusion in our daily lives. Now, there is a link to the UBC Equity and Inclusion website being shared in the chat right now. So if you're looking for some resources to start, maybe head over there. As well, you'll notice on the screen, you'll see the UBC Respectful Environment Statement, which provides the guiding principles to support us in building an environment in which respect, diversity, opportunity, and inclusion are all valued. We ask that everyone participating in this webinar, no matter where you're coming from, help contribute to creating a respectful environment for your fellow alumni, donors, guests, and speakers. And on behalf of the UBC Faculty of Medicine, I'd like to extend a warm welcome to everyone who's joining us here today. Whether you're viewing from BC, across Canada, or elsewhere in the world, perhaps tucked away on the kitchen floor, hiding from all the noise, in your basement, working away on your couch like I am, wherever you are, we welcome you and we're so pleased to have you here. We're absolutely grateful to be able to do an online webinar during an extraordinary time where we're all facing a lot of difficulty, a lot of strain, and a lot of change. So we're grateful to have you here with us. Now, a quick bit of housekeeping before we do get started. If anyone is experiencing any audio and video issues, I know that's common, please don't hesitate to reach out via our chat feature in the GoToWebinar for assistance. I know I've had to use that before, and feel free to use it so we can make sure you can see and hear everything that's going on today. So, you know, the big question really is what is virtual health? Virtual health incorporates the use of technology to connect patients and their care team. The goal, of course, is to provide patient-centered care and remove barriers to access using tools such as what we're doing right now: video conference, email, and text messaging. The UBC Faculty of Medicine is leading knowledge and innovation to transform health for everyone. Virtual health has enabled contributions across the faculty's 4 pillars, and that includes education, research, organization, and partnership. Now, in fact, the faculty's technology enabled distributed model of training health professionals now in its 17th year. That's incredible. Its 17th year has exposed students to the rich diversity of patients and communities across the province. You know, the global COVID-19 pandemic really did catalyze an unimaginable transformation in how we access healthcare, of course. In a matter of weeks, appointments with health professionals that typically did happen, of course, in person, were booked for telephone or teleconference to enable physical distancing and safety. Not long after, of course, health and wellness programs also moved to the online platform. But how did a traditionally slow to change healthcare system transform itself so quickly? I know that's been a really big question that I had on my mind. An urgent need for new policies, of course, was the catalyst for that. But there's much more. So with us today, we're really lucky to have three incredible experts from the UBC Faculty of Medicine tuning in from their own locations, of course, virtually, because it's 2021 and that's how it is. They're here to share their insights on how to use the technology to improve access to healthcare in rural and remote communities during the last few decades and how that has paved the way for the rapid uptake of virtual health and predictions for the future. Although they're not yet with me on this screen, I'd like to welcome them and thank them for their time. So following the presentations, I have a few questions that I'm also going to ask our esteemed experts. They're the ones we're going to go to ask those questions that are really burning on our mind. I'll be taking questions from participants via Slido. That's our online engagement platform. So you will have actually received instructions on how to use Slido in the reminder email, rather, something I also received just a little while ago. So you'll see that, and you will have already inputted some questions, but as a quick reminder, to enter your own question, please go to slido.com and don't forget our event code, which is virtual health. So the event code, I repeat, is virtual health. You can use that to sign in. You will see the instructions on the screen, pretty self-explanatory. I did it on my phone right now, and the link will be shared in the chat as well. So our first presenters, really excited to present them, extremely thrilled to learn from them and hear from them. That's Dr. Kendall Ho and Dr. John Paulovich. You know, Dr. Kendall Ho is a practicing emergency medical specialist, a professor in the Department of Emergency Medicine in the UBC Faculty of Medicine, and the lead for digital emergency medicine unit, rather. He has gained professional recognition for his groundbreaking digital health research, for applying innovative technologies to support patient transition between the emergency departments and the community. He is the medical director of the HealthLink BC Virtual Physicians Program called HealthLink BC Emergency Eye Doctorate in Assistance, rather Heidi. He is also the lead of the real-time virtual support pillar of BC Emergency Medicine Network. Dr. Ho's work has been recognized with provincial and national awards for research and education in digital health and community engagement. So much knowledge I've just told you about. He is going to bring so much to us, and I'm so excited to have him here with us. And very excited also to have Dr. John Paulovich. He's a clinical professor in the Department of Family Practice. For the past 25 years, actually, he's been dedicated to improving Indigenous health with the focus on bringing innovative primary care and specialty services. And that includes telehealth onto reserves to provide residents with timely health care. He's currently the director of the Rural Education Action Plan in British Columbia. He's also the medical director for Carrier Sakani Family Services and the telehealth sector lead for the Rural Coordination Center of BC. He is involved in many telehealth initiatives across the province and is the co-founder, in fact, and the co-lead of BC Virtual Health Grand Rounds and the eHealth theme lead, rather, for the UBC Faculty of Medicine. You know, he speaks both nationally and internationally on virtual healthcare solutions and systems. So I'd say we're pretty lucky to have both of these gentlemen here with us today. So I turn it over to you. Thank you.
Thanks, Sarah. Thank you for that kind introduction. And I want to thank everybody for the opportunity to present today to this great forum and webinar. I'm calling in today from the traditional unceded territory of the Stolo Nation. And again, it's a real privilege to be talking to everyone today and sharing this time with my colleague, Dr. Kendall Ho, who I've walked many miles with on this virtual health road. So I want to start by advancing my slide here. Sorry about this. I want to start by grounding our talk today in why this virtual health discussion is so critically important. This is a picture that I took about 2 weeks ago, recently on my way to Takla Landing. And I had the privilege of going in to Takla with the Moderna vaccine for the second round of vaccinations to the community. And as you can see, Takla Landing, the community is tucked on the edge of the east arm of Takla Lake. It's surrounded by beautiful mountains and rugged forests. Everything you see in this picture is part of the traditional territory of the Takla Nation. And I think the story of virtual health can be best appreciated by understanding the challenges that a community like Takla has to face on a daily basis. And I think the other part of the story that I really want to underscore, especially through my lens as a family physician, is that virtual health is really a story about human beings. It's not a story about technology. It's really a question of how can virtual health help support the most vulnerable communities and the most vulnerable providers in our province. That's really the essence of what we have to grapple with and what we have to address. Takla represents many communities that are tucked away on the edge of a lake, on the west side of Vancouver Island, on the central coast, at the edge, of a large lake, a large river, geographically very far from any larger health centers. These are communities that are really disadvantaged in how they access primary care, specialty care, emergency care. These are also the communities where we best understand what our work to do around equity, access to care, what role social accountability plays in the daily services that we need to endeavor to aspire to support communities like Takla. The other really important reason for this picture is that, and part of the story that I want to share, is that Takla was back in 2014 was a community whereby the very first cardioversion over telehealth in this province happened. It was a seminal moment in the time for virtual health in this province. We had a patient who was extremely unstable in Takla. We had a satellite connection into Takla. We had two very brave nurses on the ground, and we had willing healthcare providers who were working with those nurses. There was no physician on the ground. And through the use of technology, a patient's life was truly saved by cardioverting them in their community over this telehealth link. And so that seminal moment really set the stage for the work that's happened in the last decade around the integration of technology into an isolated community such as Takla. This picture here also tells a story of a long history working with Caris County Family Services, the Takla Nation, the community of Takla, in bringing UBC leaders and students to remote communities such as Takla to learn about how to safely integrate technology into everyday care that really resonates and harmonizes with the people on the ground. And this is a picture showing the leader of our medical school at UBC, Dr. Dermot Kelleher, and his wife Jean, Dr. David Snadden, who's the ex-rural chair, and Privia and Chelsea, who are medical students at UBC. It's also a picture of Mr. Alvin Jacques, who's now deceased, the man on the right, who was actually the patient who I spoke of in the previous slide, who was cardioverted. This picture is really to help everyone on this call today with a bit of a reality check. So the reason I put this picture in is to really clarify and illustrate the two worlds that coexist today. And so the picture on the left is the opening the doors that open into the emergency room of Vancouver General Hospital. The picture on the right is the health center in Stewart, BC. What I want people to think of is that the very same critically ill patient can present to both of these places. On the left at Vancouver General Hospital, there's a large team that will await and accept the patient through those doors. There's also a larger cohort of healthcare professionals in the whole facility of Vancouver General that will work together to collaborate to give that patient the very best care that they deserve and require. On the right in Stewart, that same patient will have a single doctor and a single nurse to help manage their healthcare needs in that moment of time. There is no larger team to draw on. There aren't any people to call on in the community who can assist in the medical management of a critically ill patient. They are hundreds and hundreds and hundreds of kilometers away from a larger center. And so the question really, again, to bring us down and ground the conversation is, how can virtual health, how can a thoughtful network of virtual health providers wrap themselves around a community such as Stewart and TACLA to allow them to access very high quality care, high quality support, the very best support, so that those patients in those communities can really acquire the same level of quality of care, of compassionate care, of thoughtful care as those that receive in a larger center such as Vancouver General Hospital. This brings us to the point of the story around the time of the pandemic, and really the real-time virtual support work, which I want to talk about and mention right now, was really forged in the crucible of the pandemic back in March of 2020. Essentially, the real-time virtual support team or network, RTVS as we call it, is really synonymous with call a friend. And so I'm going to explain in the next few slides about what this really is in general terms. So I would ask you to imagine two components to the RTVS team and two pathways, if you will. Those that support patients, and the second pathway that supports providers. Understanding that, as I alluded to in my opening remarks, that we have many vulnerable patients and vulnerable healthcare providers in this province. And so last spring, as the pandemic was descending on this province and around the world, and we were listening to and seeing stories, horrific stories from places like Italy and China. Many partners came together in a very condensed amount of time to work together in the most collaborative fashion that I've certainly ever experienced in 25 years to enable and create these pathways that I speak of. And quite quickly, our colleagues and friends at the First Nations Health Authority, working with our RTVS team and our really core partner in the RTVS family, put together the First Nations Doctor of the Day program with a complementary First Nations substance use and psychiatric service to support all Indigenous community members anywhere in the province that required access to care. So Indigenous community members who found themselves unable to access care for whatever reason could access virtual services through this First Nations Health Authority-led initiative. In a similar fashion, the 811 nurses line in BC that's been providing service to patients in British Columbia for many, many years was overwhelmed during the time of the pandemic as it started. And so as a complementary approach, and one that Dr. Ho is going to speak to, created the Heidi Physician Network to help support the Nurses 811. And so both these virtual supports help augment access for patients all around the province. To complement the patient-provider pathways or the patient pathways of support, we created RTVS provider-facing pathways. And this slide highlights kind of four pillar virtual pathways: Mabel for maternity care, Charlie for pediatrics, Rudy for rural generalist care, Rosie for critical care. These four main pillar kind of acute care supports, if you will, are 24/7 available for any healthcare provider in rural, remote, or any Indigenous community in this province. They are, at a moment's notice, will appear over the Zoom platform to assist in whatever capacity is asked of them. So whether it's in Takalani, or in Stewart, or in Atlin, or in Elkford, or in Port Hardy, or in Lillooet, any healthcare provider can access these services. As a complement to those provider supports, we also created kind of less urgent Monday to Friday pathways for other specialties such as dermatology, rheumatology, the thrombosis clinic, hematology, chronic pain, and the list continues to grow. So these pathways have been evolving since April 1st, and they're on a daily basis providing support, again, to these most remote and vulnerable providers and communities. I'm going to now hand it over to Dr. Kendall Ho, who's going to continue on and talk a little bit more Heidi, as well as some additional things. Kendall.
Great, thank you, John. Really appreciate it. And again, thank you very much for everyone taking an interest. What would it be like for our citizens in British Columbia? John has spoken about the importance of the health providers forming a network through the province. For the patients, for the individuals in the citizens, yourselves, we have two pathways for patients connecting with health professionals through virtual care. The First Nations Virtual Doctor of the Day has been tremendous in looking at a provincial service to our patients. This Heidi service through the 811. 811's been there for more than a decade. Some of you may have used the service. When you call them, very, very effective in connecting you to a nurse to provide you with health information. At the critical time of COVID, as John talked about, that there was a significant rise to the number of calls to 811, and the disease of COVID was new. And so very fortunately, a group of us as virtual physicians were invited to join 811 so that the nurses and physicians work together to support our patients. For example, today, if you were to call in to 811 and ask a question, you will be, if it's a health problem, brought to a nurse to support you at the time of your need. And with the rights, if there are some questions that require a medical doctor, the nurse will certainly bring one of us in. And in fact, there are 60 of us now working with 811 so that we will support our patients to answer their medical questions. We have 5 functions. Number 1 is to make sure that your questions get answered. Very important. Secondly, we want to make sure that the reason you call 811 is because not only of the illness, but the anxiety behind it, or the issues that you need addressed. So we want to make sure that on a mental health point of view, we also support you very strongly on that. The third is we want to provide you with the best advice as to whether you need to go to hospital now, or you can stay home, or you need to contact a family doctor. And the fourth function is we want to bring this information very closely to your family doctor so that your information will be continued throughout the time. And fifth is we want to monitor COVID as a disease itself. And so since April that we've set up the service, we've now talked to 25,000 callers together in British Columbia. And so I hope that this virtual service, again, will be very helpful to our patients, just as what John talked about, our colleagues supporting each other as a parallel system to support every citizen in British Columbia for access of care. Next slide, please. And John and I feel very, very fortunate. John, if you can, thank you. John and I feel very fortunate that we in university, because not only as practitioner, we can tee up these lines, but using our academic understanding and experience, we can do a good evaluation to make sure that it's not just about health professionals feeling great, patients feeling great, and they do. But is it the right service at the right time for the right patients? And in fact, these are some of the evaluations that we've been doing for the past year. Look at, is it reducing the government cost, but not at the expense of excellence in service? In fact, equity of access of service is the primary reason why we do those. And so you can see these metrics that we're trying to measure so that we can bring UBC's academic rigor to support clinical care so that patients get their best care. And my final slide is the next one. At the end of the day, there are 4 key things we want to make sure we do. Number 1 is the cultural safety and humility that we practice in virtual care. Secondly, we want to make sure that every patient finds that there's a virtual way to have a safety net. So at the time of their needs, that there is a service supporting them. And the third is that we want to make sure that our patients are supported well by our publicly funded system. So wherever you enter our health system, that our health system will funnel you right to the place where we can provide you with continuity and longitudinal care. And finally, it's about fire station. When a fireman, a firewoman put out a fire, we need them. But between them, what they do is they build up community relationship, education, capacity building. Again, as a university, we want to make sure that not only do we deliver excellence of care, but we make sure that with education, with practice, we engage with all the communities so that all of us keep our British Columbia safe, so that every patient get exceptional care in British Columbia. So thank you very much for your attention. And my last slide is the next one. And John and I are really not only the two of us doing, but there's a whole group of organizations working together. So I want to acknowledge that this community is working together to support virtual care in British Columbia. Thank you very much. And maybe I'll hand it back and Sarah.
Thank you so much, John, Kendall. I'm very, very excited for the Q&A portion of this because I know I have a lot of questions piling up, but you've definitely enlightened me a lot, and I'm sure the hundreds of other people that are watching right now. Up next, I'm really excited to say we have Dr. Silke Cresswell, rather. She's a movement disorder neurologist, an associate professor at the an associate professor and Marg Meikle professor in Parkinson's research at the Javed Moaffaghani Center for Brain Health and the UBC Movement Disorder Clinic. Dr. Cresswell's clinic, you know, she's extraordinary intelligent human being who has just taught so much to so many people. The Center for Brain Health and UBC Movement Disorder Clinic is also part of her livelihood, her life. Dr. Cresswell's clinical and research work focuses on this holistic, interdisciplinary approach to the treatment and prevention of brain disorders, including interventions targeting physical and emotional well-being through active engagement in exercise, art, mindfulness, nutrition, enjoying nature, and of course, community building. She's investigating the role of the gut microbiome and nutrition with the goal of finding new approaches to the neurodegenerative disorders that we've all heard about. Of course, during the pandemic, the BC Brain Wellness Program she co-founded in 2019 went virtual and of course expanded greatly, providing a lifeline for British Columbians like myself living with chronic brain conditions, many others out there, their care partners and healthy agers. You know, she's really been able to bring in so much insight and has taught so much to so many, and we're really excited to have her here. Welcome, Silky.
Thank you very much for this very generous introduction. I'm going to share my screen now. And thank you very much for having me and the opportunity to speak to you, and a very, very warm welcome, of course, to everybody. Should now come on. There we go. So I'm going to talk about the BC Brain Wellness Program and the virtual transformation that we underwent last year. So the BC Brain Wellness Program was founded, I'll give you a little bit of background information here, to really create a community for well-being, and particularly for those living with chronic brain conditions, their care partners, because they often fall through the cracks, and everybody who is aging, which is really all of us, so healthy ages. It is a collaboration of actually many players and people, particularly the Javed Moaffaghani Center for Brain Health and here at the UBC Hospital, which you see on the upper left-hand side, and the Alan McGavin Sports Medicine Center with our co-founder, Dr. Jack Taunton. And the reason it came about was that at the Javed Moaffaghani Center for Brain Health, we have a really extraordinary combination where we have clinicians and clinics in both neurology as well as psychiatry, and we have scientists, everybody working really to improve care and knowledge about brain conditions. We also have what I call here the brain users, everybody who comes in to get treatment for their brain conditions. And the reality really always has been that patients would come in once, if they really come frequently, maybe 4 times a year, and to get an exam, essentially have a short discussion and be told what to do, which medications to take and to please exercise. And we found that it really, what we really need for the center to be true to its mission is to bring the brain users in much more, to involve people actively and engage in both the activities as well as the planning and the feedback of the programs. And so when we talk about brain users, we're talking about individuals living with these chronic brain conditions. And so this could be Parkinson's disease, which is of course my specialty, Alzheimer's, multiple sclerosis, traumatic brain injury, etc. The care partners, as I said, they often fall through the cracks, so really important to involve the care partners, and healthy ages. And when we talk about brain wellness, of course, there are many different definitions out there, but we're really talking about a holistic approach to this. So it involves the emotional, the social components, of course, the physical components, cognitive components, and spiritual components. And the lifestyle interventions, which I really prefer calling the foundations of brain health, are things such as exercise and movement, nutrition. Really is, you are what you eat. Sleep, being in nature, creative pursuits, so music and other arts, learning and ongoing cognitive activity, being in the community, being part of a community, having these relationships and fostering them. Hearing is actually a very important factor in brain conditions as well. And then, of course, addressing risk factors, medical risk factors, and stress, such as through mindfulness. And so, made possible by very generous donors, we were able to launch the program on October 5th, 2019. And as you can see, we are here in person. And this is at the Javad Morafagian Center for Brain Health and the Al McGavin Sports Medicine Center. We had the opening, which was a fantastic day, followed by pilot programs that we ran for exercise, for Wellness Wednesday, music, how to cope and living your best with the chronic brain conditions, etc. Well, one has to say though, you just saw the vastness of our province. We were all still kind of on this tiny tip here where UBC is, and this is specifically here. So really, through the in-person program, although we had always planned to expand this throughout the province, really what we're offering was a program that was physically situated on this peninsula, and a fairly expensive peninsula at that. So you see, anybody who wanted to come to the programs really had to either live close by or travel. So in a way, with the COVID pandemic really reaching BC in earnest in March, there was actually a transformation happening, which turns out to be very much a silver lining. So we all know what happened about a year ago, mid-March 2020, community centers, gyms, health programs, along with the rest of public life, were severely limited or closed down altogether. In addition to the physical isolation, social isolation became a huge problem. We certainly all know about those heightened anxiety levels, and certainly something I've observed in the clinic as well. And we as the BC Brain Wellness Program, as you saw until then very much in person, had to pretty much stop those in-person classes. That was mid-March. Now, it was also the end of our winter program, and we were about to start the spring program, due to start in early April. And lo and behold, by early April, we had actually transformed the program to be entirely virtual, to be entirely online, with actually an expanded offering. And we're now able to really reach potentially the entire province. And what happened in the next few months was actually very remarkable, and I think was completely triggered not only by the natural growth of the program, but really by this virtual transformation that just set it on a different plane. So in the fall and winter of 2019, 2020, we had 5 to 6 different classes, whereas in the spring then, so in April, we nearly doubled that to now 11 classes, and we have grown ever since, and now we're in the winter 2021 season, and continue to offer a vast array of different classes. We provided during that time, from April to November, 465 hours of free programming, because the classes are all free to our participants, thanks to our very generous donors, and that makes a big difference to our participants who have often given us the feedback that this low barrier and accessibility is really important for them. And so we've expanded classes. This is all on our website as well. We have a range of exercise classes. We have what we call the expression and creation classes, which are creative classes, but there is also return to roots gardening. There is improv theater for Alzheimer's and dementia. It's the weekly dose of laughter. There's improv for brain health. There's living your best with a chronic condition. We have mindfulness classes. We of course have music, which is a very integral part of the program, and then we have educational classes, such as the monthly Wellness Wednesdays, where we have talks and practical exercises around topics regarding brain wellness. And with the reach, the increase of the reach and the increase of the different classes, our user base also grew quite substantially. So from about 75 participants of the in-person program in April, we are now, actually, as it happens, this is the number from November, but we are now over 700 people strong who are active users of the program. And these 700 people have participated just over 4,000 times in different classes since April 2020 and since we went virtual. We also provide educational opportunities. That was another issue that, of course, impacted life at UBC. There were reduced opportunities for learning for students during the pandemic, particularly in the health sciences. And so the BC Brain Wellness Program offers work-learn opportunities for students, as well as volunteer positions and research opportunities. We currently have, give or take, about 30 students participate with the program. We have students from a very wide range of disciplines, from physiotherapy to medicine, neurosciences, integrated sciences, kinesiology, nursing, occupational therapy, and of course music. And we also, in addition to providing educational opportunities for the students, are also providing educational events, as mentioned, but the Wellness Wednesdays for participants and the public, as well as educating professionals. So we have train-the-trainer events. The impact for the participants was very much that suddenly we had a province-wide reach and beyond. Actually, participants come from across BC, as well as from other both provinces, as well as in some cases even countries. There has been feedback from our participants that say, well, it also removes some of the barriers because they can now participate from their own home. And if they don't feel well on a particular day, let's say they have, dystonia, and the dystonia, so this a involuntary posturing, let's say, of the head is acting up that day, you just turn the camera off, but you're still part of the community. Now, obviously, what is required is internet connectivity, a certain degree of technical literacy, or at least somebody who can help you set this up. And so we made, we paid a lot of attention to providing technical support to set up these Zoom sessions, because this is really for people at home. And we also have an outreach program for those who do not have computer or internet access, and we have volunteers, again, volunteer students who of course get trained first for telephone outreach. This has been for sure a learning curve for all of us, because we had to still have to deal with the technical aspects of that, but also figuring out how to reach people who might either not have that level of technical literacy required, or who just don't have the access to the internet. So of course, the last thing we want to do is to create another barrier. But I think we really succeeded for those who are participating to create an online community of well-being during times of very limited physical and social interactions. And feedback from our participants has been that this has really been serving as a lifeline for them. And so in summary, We are looking and already working on integrating the clinical care, research, educational, and program delivery aspects to really make these lifestyle interventions part of our care that we are providing, make it interdisciplinary, and it's a constantly learning system. So we do the research and learn from that and then implement that again. Being inclusive is a central value. And what we're really trying to offer is a personalized lifestyle intervention to support brain wellness for those living with chronic brain diseases, care partners, and healthy agers. So it is the quality of life aspect and living well with brain conditions, as well as the prevention. We want to create a network of brain wellness hubs across UBC, both in person as well as virtually. And with that, I leave you with a big thank you from all our instructors. This is from one of the Train the Trainer instructor days. So the way to say thank you or to applaud on a virtual call, I learned, is to do the hand wave. And with that, I thank you very much.
And I give you one of these and I say thank you so much for doing this, Silky. I really appreciate learning so much from you, learning so much from all three of you. So I know we're going to be welcoming you back in for the Q&A, but before we get to that, for our last presentation, we are going to welcome back Kendall and John, as you can see them popping up on the screen, to speak to the future of virtual healthcare. So I leave it in your capable hands, gentlemen.
Thank you so much, Sarah. Ladies and gentlemen, John and I had the pleasure of talking with you a little bit about virtual care. You know, today, seeing a doctor, seeing a nurse, seeing a team on virtual care is great. It's really cool. But what would virtual care look like tomorrow? That's what we'd like to bring to you in part 2 of this discussion. John and I feel very, very fortunate. We're in University of British Columbia. Not only do we want to define the best practice of what healthcare is today, and Silky also gave you an excellent discussion about best practice in brain health today, but how do we continue to advance what we do? And that's where research comes in. And so very fortunately with University of British Columbia and our faculty, we have the opportunity to apply for research grants. Also, thank you very much for the UBC Development Office and the support of our donors, that in a combination of scientific funding from governments, from research institutions, and also donors, that we have these opportunities to do excellent research. And so what I'd like to do is I'd like to ask John first to talk about the research that he is really excitedly carrying forward. And then I'll also talk about some of my research. Both of them will inform what virtual health will look like tomorrow. John?
Thanks, Kendall. Yes, this is a very interesting and exciting time. What I want to share with everyone is some very new and exciting news around technology such as drone technology, as well as point of care ultrasound. And both these technologies really augment and are additive to the virtual health story that you heard about earlier in our presentation. So the drone transport initiative is really an exciting new collaborative process led by UBC and a host of partners, not unlike the virtual health work that we've talked about earlier. Drone technology stands to really support remote communities such as Takalani that I spoke of earlier in my presentation. And in this particular drone transport initiative, the indigenous community of Stelako, the Stelako First Nation, is really just a wonderful opportunity and co-creator, if you will, in understanding how drone technology will augment care in a community such as Stelako. And so through the UBC-led initiative, we were lucky enough to be granted a TD Ready Challenge grant for $750,000 to propel this drone transport initiative forward, so that we can better understand as a collaborative what it means to safely, thoughtfully integrate drone technology into the healthcare space in a remote indigenous community. What do we need to learn about on-the-ground resources, both the infrastructure and manpower? What are the logistics of moving the drone from A to B successfully and then back to A again? I think sometimes it's helpful to think about very black and white examples. In the time of COVID, for example, in a community such as Takla, getting a simple COVID swab is a real challenge, not only to acquire the swab, but then what are you going to do with it? Takla landing is hundreds of kilometers away from a center that can actually analyze the COVID swab and give you a test result. And so understanding that people have to transport in today's reality, people actually have to transport that swab from A to B. They have to go down dangerous logging roads. They have to sometimes fly. They sometimes get seriously harmed and sometimes even killed transporting medical supplies. And so this story about the drone technology is hopefully the beginning of a story that will help bridge some of those gaps and more safely integrate itself into medical supply chains throughout rural, remote, and indigenous communities of this province. And that's a really exciting thing. We're starting the journey here in 2021. And I think that as the years go by, we will learn more about from the research and evaluation of this project in order to build and take this further into the future. So beyond the pandemic, we continue to have natural disasters, other external forces that really create barriers for communities such as the Stelako First Nation in how they access care and how they access resources to support healthcare. On the right side of this slide is a picture of a stretcher in an emergency room in a rural and a remote community in British Columbia. There's a point of care ultrasound machine by the bedside. And point of care ultrasound, otherwise known as POCUS, is a really growing area of technology and support to augment care in all aspects of healthcare. In particular, in rural healthcare, many rural health providers are becoming very fluent and experienced with using point of care ultrasound at the bedside. With the pandemic came a barrier to healthcare providers being able to access educational opportunities around point of care ultrasound training. Traditionally, people would go to larger centers to participate in learning workshops around point of care ultrasound. That all came to a halt with COVID. Through partnerships with the UBC Continuing Professional Development, through the Rtvs network, through the House program at UBC, we've been very fortunate to be able to really innovate in how we address this gap in education. And so more recently during the pandemic, through UBC CPD and the House program and many of the other partners that you heard of today, we supported a remote point of care ultrasound course in Fort Nelson, BC, which was all virtually enabled. And so people learned at the bedside by virtual educators, and the people on the ground were able to connect through a link, not unlike the one we're using right now for this webinar. And we're learning a lot about how to educate to the highest level, how to become better and proficient virtual educators, as well as learners. And the bidirectional learning is supported so well by the technology that we're really pushing the limits and understanding more about how we can safely support POCUS. Moreover, we're also embarking on a research project to delve into how ultrasounds such as an echocardiogram is, or an ultrasound of the heart, is performed in a rural remote community, and those images shared back to larger centers where an echo specialist can interpret them, can support the generation of the images if need be at the bedside, and provide helpful information to patients and providers in rural communities to lessen the need for patients to have to travel unnecessarily to larger centers. And we know that geography, we know that time away from communities, we know that there are cultural barriers for people accessing imaging and other healthcare services in this province. So this becomes a way to transcend some of those historical barriers and really deliver very innovative and necessary medical investigations in places that traditionally this couldn't exist. So very exciting times, and we're just starting this work. But I think UBC, all the rural physicians and communities and partners that we spoke of are very well positioned to take this work into the future, to learn from it and to build on it and really become leaders in this healthcare space. I'm going to pass it back over to Dr. Ho for the remainder of the presentation.
Great, thanks, John. By now, ladies and gentlemen, you get a sense that virtual care is not only a kind of novel way to deliver healthcare, but at the end of the day, the heart of it is that we want to be patient-centered, we want to be community-centered, so that the patients can receive the type of care that they can appropriately so at their homes, in their communities. And so not only on our current delivery of services in virtual care, we want to do that. In our research, we also are doing that. And so I'm going to share with you 2 additional exciting areas of using sensors and wearables for patients at home. And then secondly, how do we leverage the data of the patients to also serve our patients better? This is a study that was funded by the Canadian Institute of Health Research. It's a 4-year study looking at, for patients with heart failure, how can we support them better at home? If all of us here in this virtual room has heart failure and we get admitted to the hospital, our heart's not working well, the fluid starts to back up in our lungs, that we found that in fact 1 in 4 to 1 in 5 of us need to be readmitted to hospital within 1 month of discharge from hospital. And so what we want to do is to say, if we can provide patients at the time of discharge, send them home with a blood pressure cuff, with a weight scale, with a wearable oxygen saturation monitor, and we use virtual care like this to support our patients, can we improve the care? And so we did a phase 1 using this in Kelowna, St. Paul's, and VGH. And we found that in one of those yellow tickets that you're seeing, that we're able to reduce readmission to hospital by 59% and decrease emergency department by 44% and decrease per patient cost by 44% without asking the patient to take 1 more pill, without doing anything different except to have the technology available. And in fact, the quality of life is incredible. As a researcher, I love that first yellow box, but in the middle yellow box, I got really excited as a clinician. The patient said, this is the best I've felt in 2 years. This is the longest I've stayed at a hospital. I may not let TELUS, which is the company that we work with, provide the technology. They want to keep the technology. And so these are what excite us as researchers. And subsequent to that study, we have now done 21 communities in British Columbia so that we can understand how this technology can be applied both in rural remote, regional, and urban centers. But wait, here's another really interesting thing. We look into the data, which is the graph here. You can see that in the top graph is about their weight, and the second graph is about the blood pressure. The top line is their high blood pressure or systolic, the bottom is diastolic. The third is the heart pulse rate, how fast the heart's going. The fourth is the amount of oxygen in the blood, oxygen saturation. The last is a calculation. Now, John, if I can ask you to advance about 4 clicks or so, that you can see all those different things. And why do we track it for this particular one patient? And it's because of this. And keep clicking one more for me. We also asked the patient, and one more, you know, how are you feeling? Do you feel fatigued? And so at those points when they fatigue, there's a square there. Did they have to see their family doctors? Is the golden circle. Did their heart failure get so bad they need to go to emergency department, which is the pentagram, that's red. And so we mapped it onto this map. And the next click is going to be very important. When you look at the graph, they all kind of look, well, you know, the weight is coming down overall, the blood pressure is pretty stable, the pulse rate is coming down, that's great. But one more click, at that point when the patient is fatigued, you suddenly notice that the weight hasn't really come down yet at the beginning of that. Yet their blood pressure has gone up, the heart rate has gone up, peaked, and the oxygen saturation has dropped. At that point, the patient says, I feel fatigued. Now, in fact, if we can, at that particular point, intervene, then you notice that the day after, there's a red dot. That patient went to emergency department. If we can pick up the day before based on the data that in fact that patient's feeling fatigued because of all those factors, we could intervene even earlier on to say, oh, maybe you should restrict the amount of fluid you drink. Maybe you should take an extra pill. Maybe you should make an appointment with your doctor. So in some ways, it's kind of like every morning when you wake up, you kind of look at your phone or look at your computer and say, what's the weather like today? If we can do this data so that when you pick up your phone in the morning and then you turn on the phone, you say, well, today is a great day because your blood pressure is very good, your weight is excellent. So go out and walk because the weather is fantastic. Or another day, well, you seem to have gained a little bit more weight. You seem to be, heart rate's a little bit worse. Are you fatigued? You may want to do something. That truly becomes very, very personalized, and the data becomes very important. Next slide for me, please. And so the sensing is very important, and the data is very important. And also, when you think about, for example, now I'm seeing you through this. It's great that we get to talk, but I don't really know what your heart rate is and what your oxygen saturation is. And of course, you can buy equipment so you can do that. But what if we don't? One slide back. So we're working with National Research Council in looking at how do we do touchless sensing. So in fact, by you looking at the camera, that we can detect your heart rate and your oxygen saturation. That is going to take us in a big leap in virtual care so that we can actually help and understand where the patients are while at home, and do they truly need to go to hospital, or they can be monitored at home or see their family doctor. Next slide. And I think this is my final piece about some of the sensing. Recently, we got another grant with the company who's very interested in robots. And so we try to figure out, can we use robots to remotely examine patients? The advantage of that is the robots can be cleaned by disinfectants. For people coming to other people's house, that's very difficult. But for a robot to be able to do that, we can do that, and we can do remote examination of the patient, not only detecting one or two things, but actually check out a whole bunch of things. So how can robots support virtual care? It's another tremendously exciting opportunity. And that's why we get a chance to work with national organizations. We get to work with national funding bodies. And we also very fortunately get donors and get support from foundations so that we can carry out these type of research to extend the reach of virtual care. Next slide. And so what we really hope to be able to achieve is this. When people have diseases, not only can we use technology to make diagnosis when they are feeling unwell, but we can also start treating them and remotely monitor these patients together. And then we know the duration of how well they recover. And so with that data, we can then start to detect, just like remember that fatigue, we can start to detect a certain pattern of when they may need intervention. And over time, as machines start to learn more and more, working with health professionals, we can start to predict and help the individuals. And the patient themselves can participate and understand that that prediction is something they can use to look at their mobile phone and understand today is a great day. I'm feeling fantastic. I'm going to keep feeling great today. And so again, these type of research is emerging. And at University of British Columbia, we combine our research with best practices that we can establish today as virtual care to advance care so that patients can receive exceptional health services. And again, thanks to donors, thanks to UBC development offices, thanks to the opportunity for us to work with governments and work with our communities together, that we can carry these type of virtual care out. And Dr. Silky with her brain health, that all of us can improve the way that we deliver healthcare for today and tomorrow. Thank you very much. And I want to hand it back to Sarah.
Thank you so much. Kendall, John, learned so much from you. I'm now also going to invite Silky back so we can all be on the screen together for the Q&A. I know a lot of questions have piled in, so I am going to throw quite a few questions at all three of you. I guess in the simplest ways you can answer them so we can get through as many as possible, because I must say you three are a hot commodity. A lot of questions coming through. You're very popular. I know I have a lot of my own questions as well. So as a quick reminder, I am going to go and ask a few questions of my own before moving moving into the audience questions from Slido. So to input your question, please go to slido.com. And as I mentioned earlier, use our event code, which is virtual health, to sign in. You'll see the instructions and the link being shared in the chat once again. So feel free to head over there. And I say, let's get started, gentlemen, ladies. Let's do this because a lot of fun questions. I think this one's really important, and I've also been thinking a lot about it, and I'm going to ask it to all three of you. Whoever feels best equipped to answer it, go for it. Is our data and privacy safe when we are seeing a healthcare team virtually? I know that's a big question out there.
Maybe I'll jump in first a little bit. I think in terms of the publicly funded health system, privacy is very important. The electronic medical record, the electronic health record, all those are very important, and how professionals are trained to make sure that we keep the privacy and confidentiality. However, when we move to things like this, and where patients themselves start downloading type of apps and things like this, that's different. And so the challenge is, how do we make sure that the whole system create data that could be safe? And also when patients and health professionals use their own equipments, how do we also make sure that we keep safety and keep that in mind? And how do our publicly system, when they interface with data like this, to keep protecting our system privacy to be safe? It's a big question. It's a very important question. And it's a question we keep wanting to get better and better over time.
John, Silky, anything you'd like to add in for that? All right, we'll jump to the next question then. I want to really ask you, how will we see the benefits of virtual health integrated with traditional in-person care in the future? Sort of this combination of the two. Will a hybrid approach actually give us the best of both worlds?
I can jump in if you want.
To John. I think John will answer this very, very well.
It looks like it's yours.
Yeah, thanks for that question. I think it's helpful to look at virtual health and in-person care, if you will, face-to-face care, as two sides of the same coin. And really, when we're thinking about moving into a realm of patient-centered care, family-centered care, team-based care, it's really understanding in any moment in time what the needs of the patient is, and how do we then customize the care modality to best support the patient. And so we know that prior to COVID, we had a system that was heavily invested in the face-to-face world. And in fact, at the time of the pandemic, created a lot of vulnerability for patients because they couldn't access care. And so we also understand that on any given day, there are many patients who can't access care. They can't get to healthcare providers. They don't have transportation. They don't have childcare. They don't have the physical means. They're frail. They're elderly. There are many reasons why patients can't access care. Sometimes it's the weather. Sometimes it's a flood, a forest fire. Sometimes there's great distance. So the right modality of care has to take in many things, and we have to look at a patient holistically as to what their needs are. And so I often explain to learners about sometimes a medical presentation may necessitate medical investigation, such as somebody maybe has injured their wrist and requires an x-ray. But the x-ray means that they have to travel 100 kilometers down a road to get an x-ray. And in doing so, the weather outside today is very bad. It's very icy conditions. There's a lot of snow. There's danger in getting from A to B to acquire the x-ray. And so from a risk standpoint, it might be more risky for the patient to go and get the medical investigation that their presentation necessitates. But in fact, keeping the patient safe is best done seeing them virtually. So the answer is it depends, and a well-experienced and educated clinician experienced in virtual health and in face-to-face health needs to understand what best modality supports that patient at that particular moment in time.
That makes sense. And you know, the next question I'm going to give you before we switch over to the Slido questions, Silky, I feel like you actually spoke a bit to this, actually quite a bit in your presentation. What has COVID taught you about virtual health that you really didn't expect before?
Yeah, so I'm really echoing what Kendall and John have already said. The two are really complementary. And the moment we were forced really to switch over in a very short time period, of course, we suddenly discovered this whole realm of opportunity and possibility that we just ignored before, for the most part, not completely, but for the most part. And it made it much easier to include people who could not take advantage of the in-person offerings, and also include people who, not only for geographical reasons, but for reasons of their conditions, didn't feel comfortable, for example, attending a community center class, and they can now do this with a care partner as well. So it opens that to a more inclusive participation, because the care partners, as I said, they often fall through the cracks. We can check in much more easily, and of course there's the brain wellness program, but also a clinician where we now use virtual health a lot. So I think this has been really a whole new world that has been opened, and as Kendall already alluded to, there is just so much more we can do. This is, I think, just the beginning, particularly with things like remote sensors, etc., where we can just learn information that in its nature is very different from what we would get from a kind of a brief assessment, like one moment in time in the clinic. So I think this is really complementary to what we're doing in the clinic. There should be, or we will have to do, a lot of research in that realm. I think the important bit to not forget here is really the personal, emotional, social component. And I'm very curious to see how, beyond the physical benefits, the way we interact as humans, the touch, the immediacy of the interaction, even the singing together for us, which is difficult online, how that is going to play out. And I think this is just really important to do the research and then combine the best parts of those two systems. And that's where we're so fortunate to be a university, because we're not just a community center, but we can really bring the clinical care, the research, the education, and the programming together.
It's incredible to see how that's actually happened.
Mm-hmm.
And
Can
sorry,
I ask a very quick story? So completely agree with what Silke said, and John, excellent insight. I think another thing is this, that of course we need patient consent. With patient consent, we can actually see our patients in where they live. And that is so important that we could never have gotten on face-to-face care. For example, I received a call the other night about a mother quite worried about her child who fell off the bed, and the foot seems quite red. And we're worried that, do we need x-ray? Is there a problem? And so I had the privilege of her agreeing to me opening up a video. And I was able to see the child. And I said, I'd like to see the child walk. And so the mother put the child on the floor. And then I was talking to the mom. And in 3 seconds, we couldn't find the child, because the child already had run down the hallways, run up the stairs. And then afterwards, both the mom and I were reassured, oh, no, not to worry about it. We'll watch it and then go from there. I mean, that's the technology allows to do that. In an emergency, if I see that child, he or she will be hugging the mom, and we'll have to coax him or her to walk along. So that is an illustration of how technology not only is perhaps equivalent at some point, but sometimes superior to face-to-face care.
a different form of insight, definitely, and getting to actually be in that environment. I do have some questions in relation to that I can see popping up. So I'm going to say, let's dig into the questions from our virtual participants now. As a reminder for those of you out there, ask your own questions at slido.com. So that's SLIDO.com, and use the event code virtual health. So I'm going to jump straight into it. I've seen some really big questions coming in, something that actually does quite relate to what we were just talking about right now. So I've had this question come in: when should we see someone in person? Because Kendall, you just spoke about the differences of when you should and shouldn't. So when should we see someone in person?
I'm happy to jump in first, but welcome others' thoughts. I think stepping back as health professionals, the most important tenet that we need to continue to maintain is do no harm. And so the whole point of using technology or face-to-face is that we do no harm. At this point with COVID, I think most of the time we may start with a phone or a video. But of course, you call your doctor's office to make that decision together. But in the phone, one of our very important judgment call is, does this patient need to be seen face to face? And I think that's a partnership between the patients and the health professionals, and also what John talked about, the context. If it may not be such a severe health crisis, yet it's snowing out there, or in Takla, where the river is frozen, the road is going to be very, very icy to drive, we may have to take that into consideration. What is the holistic safety of that particular patient? And so it does depend on case to case, and the best scenario is the relationship that you have with your health professional to jointly decide when a person needs to be seen.
And in addition,
oh, sorry, go ahead.
Yeah, so I completely agree. In addition, I think what you already described is that the decision then also isn't, do I need to go to the next bigger center, because that's the only place I can go to, but I can go to a center or, you know, health clinic that is closer, because that clinic can now connect to the bigger center. And, you know, for me, I think it's going to be a mix. I do a lot of injections, actually also ultrasound guided. So POCUS is alive and well there. And of course, I have to see patients for that. But a lot of the people I see, I've known for years, I follow their Parkinson's, and I can do what I need for the physical exam in terms of movement, and actually even navigating gate-wise their own environment online. And then I might bring them in when I have a question that goes beyond what I can do virtually.
Excellent. I'm seeing a lot of questions coming in sort of around this, but I'm going to kind of hop to a different topic just because I think this is one that a lot of people are also wondering about. So we have someone questioning here, what does the GP service look like in the future? Also, once our GP retires, does this mean that virtual health kicks in?
So Zara, as the family doctor in the audience here, maybe I'll take a crack at that. All right. So again, I think this comes back to the thoughtful integration of virtual health into family medicine, into primary care, but also into the team-based care realm. And so it's really important for everyone to appreciate that we're very new in this space. We're not even a year into the pandemic, where we went into a predominant virtual mode, if you will, to deliver healthcare. And prior to COVID, the needle was at the opposite end of the spectrum. We were all in on face-to-face care. And so your question really gets at as to where things are going to settle out. And we don't, as a learning health systems, as all of us are learners in this space, both through our experience, but also as we evaluate what we're doing to best understand where the steady state of family medicine will sort itself out and land at, so that patients and providers understand when and where is best and how to accomplish that. And so, will the front door be a telephone call? Will it be a Zoom call, a video call? What will it be? How will patients navigate this to arrive safely at the best place? I think it's fair to say that 10 months into the pandemic, we don't have all those answers. But I think it's also fair to say that we have to be open-minded to put patients and families at the center of what we do in virtual health, as it interrelates and complements face-to-face care, so that we arrive downstream at that place that your question is focused at. So I think we'll get there. I also think that the integration of virtual health to support not only family doctors, but specialists such as Dr. Cresswell in the conversation, I'm hopeful that we're going to move into a better place whereby real-time communication between primary care clinicians such as myself and specialists and patients and their families will happen, not unlike we're doing right now, to obviate the need for people to actually travel from specialist to specialist to specialist and back to their family doctor. That kind of really fragmented care creates a lot of vulnerabilities and challenges for patients.
Great. Well, I feel like you should just know all the answers, John. You're saying you're still learning, but you guys are my three well of knowledge. So I'm asking you so many things, but we are running out of time. So this will be the final question from Slido that I'm going to put your way. So how do we develop criteria for when to allow for virtual visits versus in-person visits? And how does that work? Talk to us a bit about that criteria. I know you've spoken a bit about when you will make decisions for GP, when you should see someone for touch versus watching them through webcam, but what will that actual criteria be?
I know Silky has your hand up. Silky, do you want to go first, and then I'll follow you, perhaps?
No, it was actually for the last question to say that I don't think that we'll need less people. I think we need to integrate people better. So I don't think we can now say, oh, we won't have a crisis in, let's say, GPs because we don't have enough. We still need the same number of people, I would think. We just have an opportunity to connect this network better.
Yeah.
With certainly personnel intense.
Yeah. So following that question, Sarah, I really like that question that you just asked. I really want to thank the person who asked that question. When is it appropriate? This is where I think the relationship between the patients and the health professionals become vital. We don't necessarily ask that question when we say, when should I call a friend? When should I email them? When should I do a video conferencing? When I go knock on their door? Because there's an intrinsic relationship there. And that's why in British Columbia, we believe in longitudinal patient care. We believe in the relationships between the family doctor and the patient, and also the specialist and family doctor and the patients together. And even as emergency, we want to make sure that our patients return to and establish a very strong relationship with family doctor. And so that relationship-based care in some ways dictates and support when is the right criteria. And so the bottom line is, I think in both in the health system point of view and also in the one-on-one between patient and doctor, it's about co-creating that criteria between patients and the health professionals together. I think that would create the best system. It's not one side dictating the other, say, I want to be seen or I want to see you in virtual care, but it's about that mutuality. And that's why it starts with consent. It starts with us agreeing to want to do this together, and then over time, learn together as we move forward.
Excellent. Did anyone else want to add in anything?
I would just add, Zara, the importance of context into criteria. So again, understanding where patients are, what their needs are in that moment in time, in addition to their healthcare needs, is critically important in deciding what best modality of care supports them best at that moment in time. And so Kendall hit on the pillars of care as it should be in a patient-centered, family-centered realm, the longitudinality of it, the relationship-based relational context of it. Those are crucial and vital pillars, and certainly those are the pillars of family medicine. So again, putting the patient at the center of our thoughts around shaping virtual health as it interrelates with face-to-face care, and embracing those foundational pillars of what Kendall talked about. I think that will take us to a safe direction as we continue to integrate virtual health into the landscape of healthcare here in BC.
I must say all three of you have really eased a lot of stress for me using virtual healthcare, wondering, am I still important? Do I still matter? And I feel you've really eased those concerns. But before I close this webinar, I would like to give, of course, each of you a chance to provide a brief final thought for our viewers. Like I said, you are a hot commodity. All of you are so popular. So I'm going to go through to all three of you. Silky, we're going to start with you. Did you want to start us off with a takeaway for our audience? And what do you want them to think about first and foremost as this webinar is coming to a close?
Yeah, well, first and foremost, thank you very much for having the discussion. I think that's extremely timely, and it really has to be a discussion. I know it's just the four of us on the screen right now, but one of the really important activities that we need to pursue going forward is to have this a mutual coming together and exchange of experience, of knowledge, of preferences to really develop this framework and how we do this going forwards. And so I think we just need to really be very careful that we involve the stakeholders from the beginning to make it the best system it can be. It's an enormous opportunity. We're building something new. You know, this is the beginning of a new era, and we need to do this together.
Excellent. And I'm going to pass this on to Kendall now. Kendall, some final remarks from you as well, and sort of wrapping this all up.
Yeah, I agree with Silky. I think it's so important that this is a ground floor, that we just started our journey together. Perhaps I want to bring out this phrase, study and service. I think as a university, not only do we want to deliver the best service we can and define the best practices, and we need to work with our patients together on this, but it's also about study. It's also about not settling on today's practice, but continue to do research so we can advance it over time, so that tomorrow's virtual health will look very different from today. Different not because it's worse, but different because there are different ways that we can move forward on that. And so again, I want to thank the opportunity not only to have this forum to socialize, and also the type of support that people gives to UBC Development Office, to UBC Faculty of Medicine to do these types of research, so that we can continue to advance knowledge and care. And this type of enthusiasm and our collaboration together will surely take us to a better place tomorrow.
I'm very lucky to have invited you all three into my living room to learn so much. Would love to have a cup of coffee to learn more when it's allowed. John, I'm going to get you to wrap it up for us. Let us know if there's anything you'd like us to end off with and remember.
Well, I'll just come back to perhaps the title of this webinar, and that's the 21st Century House Call. And I think the opportunity the pandemic has given us is to embrace virtual health, to resurrect, if you will, the house call. And albeit it's a virtual one, I think it's safe to say there have been more house calls done in the last 10 months, 11 months, than probably in the last 10 years, if not 20 years. And that is just a reflection of how healthcare has gone. And this has provided patients to become empowered in their healthcare, to access healthcare in the safety of where they find themselves, if they're privileged enough to have a home. But I believe that we've entered a new era where patients need to be at the center of healthcare and the day-to-day interactions with the healthcare system. So my final thought is, again, not letting go of what has been accomplished in the last year since the pandemic started, and how we were present in a healthcare system which was mired in inertia. And the pandemic last spring gave us the opportunity to rise over traditional barriers in virtual health that we previously could not overcome. And so for that reason, everyone, regulators and administrators and health authorities and government and colleagues and learning institutions all work together in a collaborative way that really no one's ever experienced, certainly in modern history, about how we advance healthcare. And I think if we can really embrace and harness that collaborative energy and will to work together and co-create and collaborate, I think we'll accomplish great things as we move forward with virtual health. And just remember what is possible when everybody pulls together for a common good.
Thank you so much. I mean, I think you hit the nail on the head there, that despite everything that was going on, you've overcome so many barriers. All three of you, your colleagues, you've done an incredible job, and I look forward to seeing where we are 10 months from now, a year from now, when it comes to the virtual healthcare and so much more. You are doing some incredible work out there, and very excited to see what comes next. So thank you again, John, Kendall, Silky, absolutely incredible. So now thank you, of course, to all of our viewers as well, UBC alumni, donors, and friends, for joining us for this really important discussion. I know many questions were not answered directly, but we have experts here who I know you'll be able to tap on in the future and ask these questions to as they continue to grow and come out there. The video from this webinar will, of course, be available in the coming days at med.ubc.ca/giving/webinar-series, along with any links to resources that were mentioned during the conversation. You know, thank you so much for being here with all of us. The URL is currently showing on the screen as well, and it's being shared in the chat. So this is the second webinar in the Transforming Health for Everyone webinar series. It's been brought to you by the UBC Faculty of Medicine Development and Alumni Engagement. So thank you to all of the people behind the scenes, in front of the scenes, everyone working on this together to provide this incredible insight. And you know, I wish you well with this really uncertain time. I hope you hold your head up high, know that you are a part of an incredible community that is making an incredible impact. Stay healthy and have a great rest of your day and rest of your week. Thank you. And thank you like this, as Silky said.
Yeah.